Hi, everyone. Welcome to Chats with Dr. Gege. I'm very, very excited about today. In studio with me, I have Dr. Matlharomela Moagi. I hope I got it right, Doc. So, Dr. Moagi is a fertility specialist, and I've asked him to join me in studio today to answer so many of our burning questions. Since I did share my story about my journey with secondary infertility and being a mom again at the age of 40. So, Doc, I'm going to give you an opportunity to introduce yourself. Please tell us a little bit about yourself and where you trained, why you chose this profession, and where you're based, even.
Yeah, thanks, Doc. Um, I'm Dr. Mutlaramela E, or for Emmanuel Moahi, um, reproductive medicine specialist, which is just simplified by just fertility specialist.
Okay.
Because when you say reproductive, people tend to get confused. I did my specialty in obstetrics and gynae at UP, well, with the College of South Africa under UP, and then I continued to do my certificate in the reproductive medicine or fertility, also with the College of South Africa under University of Pretoria again. So at the moment, been practicing as a fertility specialist for a couple of years now. I'm with the Family Matters Fertility Center is in St. Chiron, that side of Pretoria. They call it O12.
Yes. Also, the practice is called Family Matters.
It's Family Matters.
And how long have you been a fertility specialist?
So I've been a fertility specialist for 3 years now.
Okay.
Well, I've qualified for fertility specialist for 3 years, but I've been doing fertility for the past 10 years.
Sure.
Yeah.
If I may ask you, why fertility medicine? So I won't ask you why you chose to be an obstetrician, but beyond that, what said to you, okay, I need to go further into this field of fertility?
I'm one guy that likes challenge. So in the fertility field is what they call the endocrine, where you deal with hormones. For me, they've always been so complex, and after the specializing, I realized I still don't understand how the hormones work. And as much as all we know is treatment for the fertility, but the question is, how do you play around with the hormones? Then that's why I decided, I think the reproductives for me. I've always known that I want, if should I go back and do fertility, or specialty, I want to do obs and gynae, then fertility specialist. That's how that passion came about, and it's a common problem. For me, the hormones are just complex, and I thought, let me just deal with it and get to the bottom of this. Hence, I went back and I realized the deeper you go, it even goes deeper and deeper and deeper.
Yeah.
But yeah, I think that was mostly my motivation for this fertility, and is a fertility infertility is a societal problem as well.
It really is. You know why? One of the reasons I love being a woman. I've always said that I think women are the most complex beings. The fact that, like, there's this cycle that, like, we are always on some part of this hormonal cycle that is
Yes.
going on. Like,
Yes.
for God to design that system and that it works so precisely, dates, time, hours, like, I think it's actually magical. It can only be a miracle of creation.
For sure. You know, when I actually today I was telling my young specialists to be, and those that want to be fertility, I always tell them, I'm sure you don't even know a fraction of menstrual cycle. As a qualified gynecologist as you are, if I were to take you through menstrual cycle, you realize you only know 5% of it.
Of the
That's how
exercise.
complicated it is. When you present, you've been doing menstrual cycle since medical school, but that's just scratching the surface. If we go deeper, you will realize how complex this thing is.
And can I tell you, even as a woman and even as a doctor who did do a little bit of gynae and learning the cycle at medical school. I really only realized when I was struggling to conceive, number two, how little I know about my own cycle. You know, you just all you think of is, okay, I am not on my period and now I'm on my period and then it's over and maybe there's PMS and everyone thinks it's just this phenomenon where women go crazy before their cycles begins. But I only realize how little we actually know. Do you think that it is something that every woman should fully understand, her own menstrual cycle and what each phase entails?
I think what's important is you when you start seeing your period, then with time you start to understand your cycle. That a woman that follows will tell you, I expect to see my period on this day and that day, my menstrual cycle. They might not, few only knows the exact days, but majority will know that, for example, on the 8th of April, my period is starting. I think that's what important is consistency. You need to understand your cycle so that if the 8th comes, the 9th comes, the 10th comes, you get surprised. Why am I not seeing my period? I must find out why that is the problem, because that could be the beginning of another problem. So it's very important to understand, everyone to understand their cycle, indeed.
Okay. All right. I think for the interest of time, I want us to get into the nitty gritty.
Yep.
Okay. And the issue really, Doc, is infertility. So there's infertility, there's delayed fertility, right? And then there's secondary infertility. All these problems, do you think that they are becoming more common, or are we just being aware of them more because of social media and because of the growing size of the middle class? Or do you think actually fertility is becoming a bigger problem in society?
It's a bit of the two. So it is becoming a problem. It is with the today's lifestyle, most of the things we use, what we use on a daily basis, they affect fertility without us knowing them. So we call them endocrine disruptors. So they disrupt our system. So they with generation to generations, it's going to become even a big problem in fertility. So I always tell, especially from the male, I said, if you realize in the olden days, it was so easy to conceive. With generations and generations, because things have changed, the lifestyle also, the environment, all those, they affect fertility. From the 3 generations to come, I always say, if I struggle today, my grandson is going to struggle even more. So, and the other thing is, we're also aware now of fertility. We are very conscious when you've been trying for a couple of months or for a year, you realize, no, man, I've been trying. Someone will be trying for 5 months, as no, I expect to be pregnant by now, it's not happening. So we then said to consult earlier. But today's lifestyle is causing problems. A lot of things that we use on a daily basis, unfortunately.
So, I mean, there's the things that we all know about, right? Like smoking, drinking alcohol, I don't know, lack of sleep, drugs, maybe certain medication that we call teratogens. But you are saying that there are things that we're using every day that are endocrine disruptors. And I'd like you to please give us some examples of the things that we wouldn't be conscious of.
For sure. We use every day when you go and buy a cool drink, water, you drink in that plastic bottle. So the same, that plastic bottle is, it can affect male fertility 3 generations from now. So that is what has been proven. It disrupts the endocrine system. So the generations coming from now, then that's gonna be a problem. Every day we do all the insecticides. Then when those started in the farming, we do makeups as well.
It's scaring me.
Not all makeups, but we do
Yeah.
use makeup as well. So also they have an impact on the
Microwaving our food.
yeah macro. Also all those
Mm.
they affect the fertility. Those genes then they get affected. You're gonna pass those affected genes to your daughter. Your daughter is gonna affect those genes to her daughter, and the same as the father will pass the same genes that are damaged to the son, and the son will pass it to the grandson. That's how it goes about. Then the fertility becomes even bigger problem. As the generations after generations, it's going to be bigger problem. I always say, in the olden times, there was our grandmothers. They would do less makeups. When we used to cold drinks, we used to drink the glass bottles, and things were easier. But things change with time. It's new life, environment, what we use. Now we want a decorated life, but unfortunately, it comes at a cost.
And then added to us wanting to study, follow our careers, so we're delaying motherhood. So that age factor as well.
The age factor is.
Can you tell me, ideally, right? We're not dictating to anyone, but ideally, in the ideal world where we didn't have responsibilities and money wasn't a factor, what is the ideal age for a woman to conceive?
The best time we always say is between 18 and 34 years of age. That's the best time.
18 and 34.
And 34.
Okay.
If you push it, we'll say from the fertility field, we get worried when we are about 37. We said, sheesh, I think now it looks like the eggs are running out. Because remember, when we are born, when a woman is born with the eggs that she'll ever be given in her lifetime, immediately God decide it's going to be a girl. She's going to get 20 million eggs. Those are the eggs she'll ever get in her lifetime.
You don't get more later.
You don't get more
You're
later.
born with those
But
eggs.
unfortunately, I always laugh. I said, I don't know why God gives you the 20 million when you are not going to use them. Because when you're born with 2 million, 18 million gone already.
I suppose we don't question God, but he probably knows the rate of decline of the eggs, right?
Yeah.
So that's why he has to start with so many.
Exactly. So you start there and it goes down. By the time you said, I'm seeing my periods, we're left with 300, 400,000. So, and you're going to lose ovulate every month. So, hence the age factor. So, woman, then we get a couple of women said, Doc, what can I do to increase my eggs? You cannot, because those are the ones that God has given you. So, if they are depleted, they are depleted.
So you are saying that there's nothing we can do to increase the number of our eggs. But a common question is there anything that we can do or eat to improve our fertility? I've seen, like, even on social media, I mean, everything's on social media now, like, oh, you trying to have a baby, you should be eating this, and you should. Are there such foods?
Yeah, what we do, we basically improving the quality with a good lifestyle. Then your hormones becomes balanced. Then the quality of the eggs becomes better. It's not about you increase the chance, just you get a better quality. And when your body is fit and everything is in order, it able to the hormones are balanced. So then they start get coordination. You get to get better quality eggs. When just the normal daily food that we eat, lots of those that have got lots of folic acid, they also have they improve the chances. They make the quality of the egg. Your normal veggies, normal veggies that we eat, well, we like meat, but the veggies are rich in all those your folic acids. They have your calcium. All those they improve the quality of the egg and the hormones as well in overall, and then you get the quality eggs. The number will not increase, but you get the better quality.
So there's nothing we can do to increase the likelihood of conception.
No, the likelihood of conception is just the normal healthy lifestyle. Maintain the good body weight. The body mass index must be within that range of, if you can improve it, if we're able to keep it within that 18 and 25, that's the best body mass index that we have. The body, the brain, and the ovary, they're able to function properly, regulate the hormones, which will give us that quality egg that we're looking for.
So, I mean, I'm extrapolating from what you're saying, but you are saying that being overweight, and we're not body shaming anyone, right? We're just talking about whatever, medically overweight or increased abdominal circumference can affect fertility.
It can.
But how?
So what happens, what controls the cycle is the hormone called estrogen. It's known as estrogen. So the same estrogen, how the brain detects it when it's low. When it's low, that's how the brain realize, oh, the estrogen is low, because estrogen is the one that controls the system in a female or in a woman. So it will make sure it releases the hormone to recruit a new egg. A new egg gives us that estrogen.
Okay.
So now, when we have a BMI is a bit high, you get that estrogen. You get it from the fat.
Or fat cells release estrogen.
Will release estrogen.
Okay.
So now, because you release estrogen, this is not the
one that
it's the one. It's not the one that the brain is looking for.
Okay.
It's not the one that is involved. So the brain will say, we don't need to release the egg because we are good. So then the egg will not come. As a result, it causes an ovulation. Then we will delay our fertility, that one.
Phew. So, look, I this is not an easy, let's call it a science, right, to break down. And I'm going into something even more complicated. But I really need to try, and I did ask you to not talk to me like a doctor, but just talk to me like a woman, to understand this thing about hormones, because it leads into this thing of polycystic ovarian syndrome. Because we're talking excess fat, excess estrogen, and then we are also talking insulin resistance. And I'm a bit confused as to what came first, like in polycystic ovarian syndrome. Like, is it the chicken or the egg? Do you have too many cysts and then your hormones are imbalanced, or the hormone imbalance causes you to have lots of cysts and not ovulate?
So the hormone imbalance came first, and then the insulin followed, the resistance followed. What happens, all this, remember, the liver plays a bigger role.
The liver as well.
The liver plays a bigger role as well. So there's a liver involved in all this. So when you have the ovaries, lots of ovaries that have got lots of hormones that are called androgens.
Okay.
So called the male hormones. But so there are lots. So those male hormones, they are converted to estrogen.
Okay.
So when they connect to estrogen, because estrogen controls the system, it goes to the liver. It says, when it goes to the brain first. So the brain says, responds to the high estrogen level, said, the estrogen is high.
We don't need to release an egg.
That means we need to go and release the egg. But then no egg was formed, remember, because estrogen was never low to trigger the release of the one.
Okay. Oh, and there was no egg formation.
There was no egg formation.
The formation of the egg is how the brain increases estrogen.
Yes. Okay. So the brain, when the estrogen is low, so the brain knows the only thing, according to the brain, that can increase the estrogen level is the egg that is going to grow.
Okay.
Is the growing egg. So in this case, you don't have a growing egg.
Oh, the egg is there, but it's not going to go through that cycle where it's getting bigger.
No, it's not.
Okay.
Because there are multiple, in polycystic ovaries, because they are multiple. So they are high in male hormones. So the male hormones, what it does, it's converted to the estrogen. So that means the estrogen becomes balanced or high. As a result, when estrogen is high, that's when the brain releases the egg, what we call ovulation. But then in this case, estrogen is high, but no egg was formed.
Yes.
It's going to release that hormone to come and release the egg,
But
but
there's
the egg is
no
not
egg
formed.
that's ready. Okay.
So then cells increases and increases. They increase more estrogen. Estrogen goes back again to the liver. It says, then it releases what you call the proteins in the liver. These are the proteins that carry all these hormones in the system. They're called sex hormone binding globulin. So they're the one that carries the hormones
Yes,
around
move them around the body.
in the
Okay.
circulation. But then with that, then that means we have in the excess fat, which results from that insulin resistant as well, is because of that hormone that is increasing from the brain called the LH. The one that releases the egg is called the luteinizing hormone.
Luteinizing hormone.
Is the
Does
also
it cause the
the-
insulin resistance?
then is a vicious cycle.
Okay.
So it's a vicious cycle. So it increases, and the insulin resistance increase the androgens, and they go like that.
And then the person now gains weight.
You gain weight,
And then the fat cells release more estrogen.
It's a vicious
and then the
cycle.
brain doesn't develop the eggs.
Yes.
And so it is a vicious
It
cycle.
is.
Where did it start?
So it all started, well, polycystic ovaries is you're born with it. A woman is born with it.
Okay.
So she's born with all those polycystic ovaries, unfortunately. Then with time, when she starts, but they're not active at the time until the time where now the brain starts taking over, is matured, which is time when she's supposed to see her periods. Then that's why the problem starts. But you can't really tell if this baby is born with this baby has PCOS at birth. We only realize later on when they're supposed to see their periods. Then we check, we realize, okay, here we have a problem with the insulin.
So what's causing the cysts? Is it these eggs that are undeveloped? Or
they're underdeveloped.
they just become big and they're just chilling there, not doing anything?
Remember I said God will give you 20 million eggs when you're still a
Yes.
mother's womb. So others will go, then they go away. We call atresia until you are born with the 2 million. Those, as they go through the changes, while you in the mother's womb, they go through the changes, what we call mitosis, the changes in size and the increase in size when they're inside. Others will go away and others will persist. Is all those that persist that will cause polycystic ovaries. Then you are loaded. You have a lot of eggs, but they are not functional.
And so do all women with polycystic ovarian syndrome have the full cycle as part of their story? Because like we've said, part of the cycle is I have excess androgens, I have insulin resistance, I have excess estrogen because the androgens are converted to estrogen. Do all women with PCOS have excess androgens? Let's start there.
Yeah. So they will call it, we classify them what we call phenotypes. So you have those that majority will have the high androgens. Almost all of them have high androgen levels, but then you have few those that have that a subtype that has less insulin resistant because androgen is not high enough. So the brain still has a bit of control in all those. So then you have less insulin resistant. That means they don't go the full classic polycystic ovaries. They can either have menstrual disturbances to show that the brain is trying to control, but it's
not a regular
system.
Okay.
So it's because of that ovulatory problems and the high androgen levels. But then you will have those that they're still, everything is normal. They still see their periods. The cycle is still okay. And it's because the androgens are not as high enough. What is dominant is the polycystic ovaries. They don't release enough androgens to be converted to the estrogen. So that's another subtype. There are about 4 subtypes all in all, including the classic one. Yeah.
I mean, this is now a doctor question. If this condition is so complex, should a general obstetrician and gynecologist be managing such a woman if they have diagnosed this or they suspect this?
We, unfortunately, they go through gynae, ideally, a reproductive specialist should be managing these cases. But what we try to do, because when the patient they go to to the gynae. If they have problems, they go into my gynae, I have problems, my period, this and that. So what we try to do try to empower the gynaes, the general gynaes, empower them, create workshops. We'll hardly have a congress in the country without a polycystic ovarian syndrome workshop, so that at least they get educated, because most of them, they don't understand how it works. So they just believe, I will just give these hormones, the combined hormones, or the contraceptives,
and then
they'll do the job. Sometimes it's not the case. It depends on the subtype of that polycystic ovary.
So is it possible, if you're saying a woman is born with it, is it possible to have no symptoms at all, have a regular cycle, have a child, and then later on in life, suddenly now the gynae says, oh, it looks like you have PCOS?
Yes. So it can happen. So it's just, unfortunately, as we grow older with time, remember I said what's important is also to maintain that body mass index. And so with time, as we grow older, you have what you call metabolism as well, what digest what we eat, make sure that the fat is kept in check. But as you grow older, the system then slows down. Then it's able to surface it down.
Now you're gaining weight.
Now you've been eating, they are stored in that fat, and that's how it then starts surfacing.
I see. And now with an example of a young person who's not trying to have a child, who maybe is having irregular period, is there benefit really in treating the PCOS if it's suspected, if let's say, but they don't have weight issues, like if they don't have any symptoms that bother them related maybe to the androgens, because I know the excess androgens for some people, that's what causes the acne or the facial hair. If they don't have any of that, what is the benefit of putting them on any medication?
They shouldn't. I mean, I always say, if someone does not have a problem, what are you solving? If the period this is somebody who is not ready to have a child now, she has a normal menstrual cycle, she doesn't have high BMI. If she does have just high BMI, you don't have to treat at the time. All you do, you advise the first step, the first treatment of polycystic ovaries is lifestyle. We say, keep your weight in check. If you have high BMI, lose that 10% of your weight. 100 kg, you lose 10 kg, you are 90, then your brain registers, start functioning. So there's no need for treatment when you can do the lifestyle.
Is the fear not that, I mean, I'm asking this because I know people in this situation where it's like, oh, you have PCOS, we need to treat it now. And then the fear is that it's going to affect future fertility.
Not necessarily. If you have PCOS now, my advice would be keep the weight in check, get a healthy lifestyle. In that way, then you'll defeat it.
Okay.
No need for us to start any sort of drugs, just lifestyle modification.
So there's the hormones, and then, I mean, can you share a word on those packs that you buy from the chemist that they made? Some of us drink that are supposed to boost your metabolism. Like it's like a 3 or 4 in 1 packet of different medication because now you've been told you have PCOS.
The common one that they like is called, what is contained in all of them is what you call myo-inositol. They promoted these guys, the companies. We checked and this we realized
there's no science.
There's no science behind this. It's just supplements. At the end of the day, improving metabolism, that means is a better lifestyle. A good lifestyle, it improves your metabolism, which I spoke about, with good metabolism, and they're just supplements. I said myo-inositol or folic, others. So it's just the supplements that boost your body to to function better. Your better functioning body, with or without them, the brain will work.
I mean, I suspected as much because I thought the fact that you're treating this serious condition and this treatment does not need a prescription, I was already like, something here smells a bit, but I was desperate, right? So
Yeah, it's just to improve. I mean, when you're desperate, you take anything
you
that
take
comes
anything, you try anything.
Yeah,
you
what
know?
it does is just to improve your body to function, the metabolism, which I spoke about, which I say decreases with time. So a better working body, a healthy body, the brain needs a healthy body, and then it functions better to control the system.
Okay. So I'm going to want us to talk about interventions now. And before we get to infertility, maybe let's address planning, right? So there are people who say, I'm not ready to have a child, or I don't have a partner, and I've heard about this thing of freezing eggs. Can you tell me first, when is the ideal age to do that process? And then physically, what does that process entail? Because I just see people with injections there, and I'm already like, "Kima, kima." Yeah.
So the best time to freeze, like I said, the best time, the fertility window, best time is between 18 and 34. It doesn't mean after 34 you are late. This is a baby you're 34 with a good lifestyle and you still have even more than enough eggs. That's why I said we only worry after 37. Anytime between, if you're planning, you are not sure if you're gonna want to have a baby. Someone will come in 30 who said, I don't want to have kids in this lifetime. Someone at 25, I don't have kids in this lifetime. We said, okay, if you don't want kids, the best time between those good ages, 18, 34, up to 37, if you push it, is the best time to freeze your eggs. I like giving an example. I had a young lady, 36. She's just coming because, okay, I've been alive. I've never been to a guy in here, so I just thought I should come and see you.
Oh.
And besides, I've been just taking supplements because my periods sometimes are heavy. Then I check a cancer lady. So kids, I don't even have a boyfriend. I don't want a boyfriend. Not now. The ones that I meet, they're not at my level.
Okay.
Then I check. The reserves are low. Then I said, okay, I think maybe you should consider freezing in the meantime. You don't know what's going to happen. Then that's the best time to freeze. She was 36. Already we're running out of eggs. So imagine if she came a year or two later. Probably will be less, even lower. So if you're not sure if you're going to want kids, freeze before the age of 35. Just freeze. Even if you come back when you're at 50, the eggs will still be 34-year-old.
So the issue is not the uterus. The issue is the eggs.
The issue are the eggs. The uterus, anytime, can carry the baby. The eggs, we need the fresh ones. So, yeah.
But I am surprised, or anyway, I just think that every woman should see a gynae or someone. I feel like 36 is late because the egg count is one thing, but I mean, you can even have fibroids that you would need to have addressed before. You know, you'd need to just know that I have these things. Are they growing or what's going on? You know. So, okay, now then, if we're still in the right age category and we want to freeze, what's with the injections?
So when the freezing, I need to get those eggs out. So I get them. I need to block the brain from working so that I can take over your cycle for that month.
Okay.
So I give the injections that I give in. These are the same hormones that the brain will give you on a monthly basis. The difference is this time I'm the one who's giving them. That means I'm giving a bit higher dose than the brain is giving. That means I'm going to get lots of eggs. All the eggs that I can see at the time when on ultrasound, those are the eggs that I'm going to go for. If I see 10, I'm going to go for all those 10. so that they all grow, and at least I have 10 eggs that I can freeze. That's all about it. So I just blocking, said, brain for this month, take a break. Is me now.
And you go transvaginal.
We go for transvaginal because that's where you get closer to the to the ovary.
So there's no cutting involved to get the eggs.
We don't cut anyway. So
Okay.
we just go closer to the eggs and we just aspirate them out.
Okay. And then ballpark figure of costs, because I know there's the cost in the retrieval, and then there's cost in the storage. I mean, you don't have to give me exact numbers or your fees, but like, what are we dealing with?
Definitely, the freezing is cheaper than when you do the full cycle of IVF.
Yeah.
So because this time we're just getting the eggs and we're going to freeze them. So there's cheaper. You pay half of the full cost.
Yes.
Should you come back later and said, I am ready now, I want to fertilize, that means you must pay the other half.
Yes.
So if I say example, I say the figure is 70, you'll probably pay 35 at most, just to freeze, to get the eggs, take them out and freeze them. When you come back, then you need to pay the other half, because now it's an embryo that needs to be cultured, so it must be put in that the storage so that it can grow like it's growing on the body.
And then, so there's no monthly fee of the fridge. I don't know if the eggs are sitting.
Not necessarily. All is just you might have just, not monthly, just depending on the number of eggs that you've frozen, then you might need to just check now and once per annum, which is a small figure. It will not depend on how many. It will not probably cost more than 5,000. It's just to check that they are still frozen they kept them frozen in there.
So for you guys to go and open the fridge and look, you have to pay.
we don't pay. We don't open and look. So we freeze them in the nitrogen.
Okay.
Liquid nitrogen.
Yes.
So we put them in the liquid nitrogen. They stay there for years. So the initial figure that you pay is probably that half of that full cost. Is the one that I'm talking about. The other one is just for small maintenance of all those. What you call the bank charges, because you have that bank card. So it's just a small fee. That's just to keep them in there.
Okay. So that's egg freezing. Now, the lady, not this lady, another lady, did her career and finally met her husband. They are both in their 40s or whatever the age is, and they've been trying. So after how long of trying do you then have to call it and say, okay, now we need to go get help? And then what does that help look like? Are we only looking at the lady? Do you also look at the man?
Yeah. First of all, I always say, and I'm going to emphasize again, that infertility is a couple's problem. It's not a man or a female's problem. It's a couple's problem. So above the age of 40, the best thing to do is check before you start.
Oh.
So what we say is that if you are less than 35, we still have enough eggs to play with. We give you a year. So go and try for a year. If nothing happens, because we expect a normal couple, normal male, normal female, less than the age of 35, 80% should fall pregnant within 12 months. And if you're above age 35, we said, the eggs are a bit running low. We have that. We said we have 6 months to. If in 6 months nothing happens, you guys must check.
Get to it quickly.
So above 40, we are running out. You must check right there and there.
Okay.
You must say, we're at our 40s. We want to conceive. We just want to check if everything is in order. Okay. Then we can advise, because we are running out. If you are saying, I'm going to try for 6-12 months, the little that we are left with, then they go. Because the rate that you lose the eggs after 35, it triples from before 35.
Is that also how people get multiple births sometimes in their late age?
Exactly.
Because of that release of the eggs?
They release lots of eggs. So after 35, they start releasing a lot, because now we're running towards menopause. Before then, the body controls release one at a time. It moves two. But after 35, after 40, even worse, then it starts to release. But we said, hey, time is moving. Then you might get multiple pregnancies as a result.
Okay, so I know there could be many, many problems as to why a couple is not conceiving. I mean, they have to make sure that they are engaging regularly, that they know the cycle when they are ovulating. But now, when you have retreat, so say you intervene and then we agree on IVF. Why does it sometimes fail? Why does sometimes we say no, someone's eggs are poor quality, they died? Like what informs all of that?
So fortunately, IVF, it is both diagnostic and it's treatment. So we have on a monthly basis when a couple tries, hence we give 12 months. They've been trying for 12 months. The baby has not been coming because probably the egg that came that month was not of good quality. The sperm was not of good quality, so there was no good embryo. So, and they were not falling pregnant. But they were just saying, we keep on trying because it is a cheaper way of doing it.
Yeah.
And it's free sometimes. But with the IVF, when we do it, everyone expects the results. If I give you a typical example, the chance of a normal couple without problems to conceive in a month is 20%. So when IVF is that month, we push it up to 50%. It's just that ours comes at a cost. So that was 20%. You can try this.
50. It's not 100.
No, it's not 100.
Nothing is 100.
So because everything depends on what we work with, what the ovary gives us that month. The eggs that ovary is going to give us that month, if they're of good quality, then they're good use. If the sperm that we have from the men, if it's a good quality sperm, normal sperm, then we expect normal genes. Because what controls at the end of the day, embryo must have normal genes as well. And also the body system, the uterus itself, it has factors that have to allow that baby to implant. The pregnancy happened by what you call inflammation. So the inflammatory cells in the body system and the inflammatory cells in the uterus must balance for that baby to implant. If there's no balance, then the risk of not implanting is high. So you need a good uterus to receive the baby. You need a good quality sperm and good quality egg at the time of fertilization, depending on what you're given that month. We work with what we're given for the month as well. It's just that we go for a lot.
Yeah. And I mean, does stress really play a role? Because I don't know if is it a psychological thing or is it actually a physiological thing in that stress releases cortisol and adrenaline and that also affects the process? Because everyone says, if you want to conceive, you must relax. And a lot of people will say, when we stopped trying and we were on holiday, then we conceived. So what is that?
Again, remember everything is controlled in the higher center where is the brain. Anything, that hormone cortisol is a hormone. When it goes to the brain at the higher level, then the brain will register it as, okay, so there's no problem down there, what you call the hypothalamus. Everything started with the brain called the hypothalamus. So anything that disturbs that hypothalamus will disturb the entire, the hormones that are produced from the brain. So when there's too much stress, then it's not more about adrenaline, it's more about that cortisol. So the high cortisol level then goes to the hypothalamus. It suppresses what the hormone called the GnRH. It's the one that hormone that need to come and trigger the other secondary part of the brain called the pituitary to release all those hormones to go and get the egg to grow. So if it's high, then it disturbs that GnRH. Hence, now the hormones become imbalanced and it doesn't happen. When we've forgotten about it, we're pregnant. We've been trying for 2 years. Now it has not been happening. Suddenly, the baby's here.
Because everything was balanced.
Everything now is balanced.
Everything was calm. It is so very, very interesting. I mean, for me, it just how, like, when I look at my babies now, I'm just like, it's a miracle. Like, they really, really are a miracle, considering how many factors, so many factors, so many steps, so many so many things had to be in balance.
Exactly.
And it's amazing that sometimes people who are not trying to have babies and don't want babies and shouldn't have babies,
They're relaxed.
They're relaxed.
They're relaxed. There's no pressure.
There's no pressure.
Exactly.
Oh my god.
So the hormones are working well.
Yeah.
Yeah.
So, I mean, in your practice, there's the science and there's all of that. But now we're talking about the stress. We're talking about people coming to you. There's family pressure. There's societal pressure. There's that thing of being broody that we women have sometimes. How do you help? I don't know if you even do, but how do you support the couples or these women who are so stressed and really, really want this baby?
It is just coming to see me is as stressful as it is already. So you cannot run a fertility clinic and not have a psychologist on speed dial. So you need a psychologist on speed dial that will calm the couple down so they understand the process and we understand how stressful it's very stressful. For the fact that you left your house coming to see me, it means already there's stress. We've been trying. So we as much as fertility, we cancel, but we cancel. There comes a point where we say, no, I think we need psychologists involved in this case for everyone to calm down and relax.
And we've saved 70 to 100,000.
And then your expectations
are very high.
And you get someone who said, this is my last money. They expect to pay and I want to go home with a baby. So it's that process that it means stresses you more than your stress as it is.
Sure. So, I mean, I don't know if I'm going to cover everything in this time. I'm feeling so stressed because I feel like I'm representing so many women, having you here, Doc. And I know you are doing a good job. You do have social media presence. And I think please carry on doing the good work.
Try.
But now, so the woman who doesn't find the one, right? So no husband or no male partner, or the one who has a female partner, and then they did freeze the eggs, and now they want a baby. What happens in that situation?
We come across them time to time. So if we have our generous gens that donate the sperm, and then we freeze them.
Is that a thing in this country?
Yeah, we have a sperm bank.
And they get paid, or what do they get? What's in it for them?
According to the law, these guys, they can get paid, especially for the men.
Really?
Yeah, for the female, there's a small fee compensation when they donate.
There's women who donate eggs?
Yeah, they do.
Really?
So those that are 1834, those are the best time. There's good donors.
Side hustle.
Yes, side hustle. Come and donate. It's regulated by the law.
Okay.
But for the male counterpart, unfortunately, is not stipulated that they should get paid because it's an altruistic thing. But there are some clinics that say, okay, maybe my thank you. But yeah, so they do and donate. So when, let's say, probably the female same sex and they want to conceive, there are two options. Do you want to bring a known donor, which is the one that you come with? Go and get a friend, can you help us? Or you want to come anonymous. So anonymous, then we have to go to the bank. And we show the profile. Because when you donate, you need the profile. We do the test as well to make sure that you are healthy. Check the profile. Say, this is the profile of the individual that donated. This is the height. This is the weight.
I need to know if I'm going to have a black Canese baby.
Exactly. Then you can see what race is the donor, so that you decide and choose. And then we either do the IVF or do the IUI. If intrauterine insemination, if you don't have problems, it's just that because of the relationship, the type of relationship that we have, even the For the males, it's different because now we need to get the uterus, which is we need a surrogate.
Oh, yes, you mean two male partners.
If it's two male partners, now we need a surrogate, someone to carry.
Yes.
So that's why now the lawyers get involved with the surrogacy. So we involve the lawyers and they have to go through the legal route, and then it's approved. Once it's approved, then we start stimulation. So now the question is, if you want to use her eggs, that same surrogate, or you want to use someone else's eggs, at least one the gene must come from one of the partners.
Yes.
Yeah.
Okay, so one guy can be like, we'll use my sperm, and the other one can be like, I don't know, we'll use my sister's sperm. So at least we're all related.
This one can say no. They will say between the two, if it's the guys, one will give us a sperm, and then we can get a donor egg.
Okay.
Or we can get the same surrogate as gives us the egg. So with this, if it's females, so we're going to use one of the females. If it's with the intrauterine insemination, we use her eggs. So if it's IVF, usually what they'll do, they want to share. So one will say, I'll donate, and one will carry. So one donate the egg, one carries the baby. So they are both, at least they have that connection. Yeah.
Okay. I wasn't asked this question. I was told a story, but a couple, the lady, let's say, has no eggs, or however that happens, they get a donor egg, and the husband, they use his sperm, and then the lady, let's say it's IVF or IUI, I don't know. Now, I've heard people say when this baby's born, now this baby kind of looks like the mom. So they say because she carried the baby, some of her genes were passed through the baby. Is that possible? In my understanding, it's not, but please.
Not necessarily. So remember, that baby does not have the mother's genes.
Yes.
But the baby has the father's genes.
The father's genes?
Yeah. So when the baby is born, there's no maternal DNA on that baby. So the mother, actually, if we put it in simple terms, not to be brutal, she's a surrogate for that time. So they all say the baby will look like whoever you want the baby to look like. Yeah.
And God as well will help the baby to kind of look like the mom for
exactly.
bonding purposes, I think.
Exactly.
Yeah. Oh gosh, so interesting. I'm trying to think while I have you if there's anything else that's super pressing that I need to ask you, because they're going to say, but why didn't you ask him about? Exactly. Why didn't you ask him about?
An opportunity.
This is the opportunity. We've spoken about IVF. We've spoken about, you mentioned IUI, but I think maybe just expand on that.
Yeah, I think the IUI was called the intrauterine insemination. It's the cheaper way of doing things for maybe the couple that have been trying, they are not falling pregnant. Then we check the woman, she doesn't have problems. You check the man, does not have a problem. Then you ask yourself, why are they not falling pregnant? Then we come with theories. So thought, okay, maybe the reason the woman is not falling pregnant, that means there's a mucus on that cervix. So maybe this mucus is hostile to the sperm. Because it's hostile to the sperm and we don't know, so maybe let's bypass that mucus and drop the sperms inside the uterus so that they can go, and also cut the distance. So that's intrauterine insemination. And again, it's that couple where the woman does not have a problem, the tubes are open, the eggs are there, but from the men's side, the sperms are not enough to go, because we need a certain number, we need a 15 million. Let's say yes, 10 million. So okay, they're not falling pregnant because they have 10 million instead of 15. We said okay, because they are here, we can just cut the distance. Let's drop them nearby, then they go and find the egg.
Okay. And then for IVF, Is there a maximum number of embryos in South Africa by law that can be put in the lady?
If it's your own,
Yes, so you retrieved 12 eggs. Now it's time to, what is it, impregnate?
let's say we have 12 embryos.
Embryos now, they've been fertilized.
They're your babies.
I can say put in 6.
Then that time comes with cancer, because now there are complications that can arise with multiple pregnancies. Ideally, we don't encourage that, because there are possible complications, the high blood pressures. Those babies, they don't have enough space capacity to carry 6 babies. So you're going to deliver the babies at 6 months. Then there are complications of prematurity. So we try to discourage that point. So we say, at least if you push it, maybe 2.
Maybe 2. And are you able to screen out the embryos with genetic abnormalities?
Yeah.
But you can't choose gender, or you can?
There are certain circumstances where legally you can choose the gender. So when we send for the screening, they check the abnormalities. By default, they tell us the gender. So, sorry. So, there are other conditions that if the woman that is the female's problem that has with the X from the female side, then we can check the gender if it's not a female or if it's not a boy. If it's a boy, then we know the boy won't have that condition.
Okay.
So then we know. So that's why we use, ideally, legally, they must be used for such cases. For medical indications. Where whether it's a boy, if he's a boy, is safe. If it's a girl, is safe. But when we send for genetic screening, by default, we get the gender.
You get the gender. And then I can ask you, I want you to.
Legally, it's not allowed. But, you mean to implant?
Yes.
Oh, no, if they're there, they're back, I have the report with your baby.
Oh, okay. Thank you so much. I think, I don't know, depending on the feedback and the questions and how people stalk me after this video, we might have to have another session.
No problem.
Is there anything that you wish people would know? Any like a misconception or a fear or a myth that you want to debunk?
Yeah, you know the problem that we usually encounter, people, they say, when you go through the IVF, that's an artificial baby, it's not a normal baby. And that's the myth that people spread out there. When we do whether the assisted reproductives or the IVFs, we're still using your own eggs. If you were to do it naturally, it was going to be the same egg that was going to carry that baby. So the difference is just how we go about this time, how we get the eggs and how we get the sperm. So that's the myth that people say, my wife or my husband says, no, this is not going to be a normal baby. It's going to be like an artificial baby. I don't want a baby that is made in the lab. So, which is just a myth that is spread out there. The aim is to help those who are trying. It's the same genes, same egg, same your sperm that will give you the same baby. If the baby comes with problems, if it was not screened, even that baby, when it was conceived naturally, it was going to be the same
It's
problems.
going to be the same. I think maybe spiritually, some people also feel like they're taking God out of the mix. But I think that if it helps them to know that we wouldn't know what we do, we wouldn't have this knowledge and these skills and this technology and this ability without God, you know.
Yeah.
So I think they should rest assured with that. But I want to thank you really from the bottom of my heart, Doc, for blessing us, for answering all these questions. And I sincerely hope that I was able to address most of your questions, concerns, and if you are on this journey, is to stay strong. And if you haven't consulted, then you should consult. Dr. Moachi is at Family Matters in Centurion. You'll find them on the internet. Thank you.